Good morning. Great to be here with folks. And Maria, pleasure to hear you give us a rundown on implementation science. And looking forward to dialogue this morning. Sidra, remind me, do you want me to share the screen and advance the slides?
Yeah, if you can on your side, but if you'd prefer I do it, then I don't mind doing it from my side.
Okay. I will do it. And we'll go to the beginning.
Okay.
So great. Let me go ahead and dive right in. I am happy to, take any questions that pop up in the Q&A as we go. But hopefully I'll get through the material in 30 or 40 minutes, and then we can have a bit of conversation. I think there's time set aside for that. So a couple of thoughts here to get us started by way of an outline. I'm going to talk a little bit about the value proposition of implementation science to public health in the global context. And I think that there are two major sort of threads to this intersection that are worth talking about. One is thinking creatively about how to use these emerging perspectives from implementation science to help solve applied health problems. And I think Maria touched on sort of frameworks and theories, the concept of strategies and other things. And I think there are many important health problems that would benefit from that type of analysis with these kinds of tools and perspectives. On the other hand, the global context is different than where implementation science emerged. And for example, as Maria also mentioned, the current compilations of strategies, for example, were derived from, expert groups that are mostly based in, the United States or Europe, and therefore will probably have a preponderance of perspectives that are most fitted for those health settings, and that might not be the same. So as implementation science sort of grows globally, there is an opportunity here for us to think collectively about how to improve the science itself. And I think the discussion here, I'm gonna try to touch on both of those points. I'm also going to draw a little bit from the HIV experience, and I know this is a group that works in a different sector of sort of health and public health, but I think was going to draw from my own experience in that space because that's the one I'm most familiar with. I'm gonna just because this is a scientific network that I am, or a professional network that I'm relatively new to, I'm going to say just a couple words about myself to give people a little bit of background. So sort of my professional course started as an undergraduate many years ago now, far too many for me to care to remember. But I studied at UC Berkeley in California and studied interdisciplinary field studies. So I went, which is basically a major that allows you to do kind of whatever you want to do. And I went to I studied this in a way that allowed me, it seemed like it was not that relevant for what I later did, which was go to medical school, but is extremely relevant for me today. And I think we'll be very interested to talk more about that in implementation science. I actually went to study acupuncture after my undergraduate degree. And I that's a whole other story, but I became somewhat disillusioned with Chinese traditional medicine and went to sort of biomedical medical school. And I was able to complete a degree in medicine, but I'm sorry, give me 1 second. My apologies, have a little bit of a childcare issue this morning. But I then got a degree in training in infectious diseases and did a fellowship in infectious diseases. I was faculty at UCSF for a number of years before coming to WashU, and I've worked with colleagues in China, Kenya, and Zambia, and mostly on the HIV response. And I think one of the reasons that I'm going to talk more about that is because in some ways, HIV is different, but it presages a lot of what I think is going to be happening globally in healthcare, primary healthcare, and multi-disease healthcare conditions. So let me start here by sort of giving us a little context, I think, for implementation science in global settings. Much of what is happening around the world can be, I think, in some ways traced to two important sort of policy documents. One is the 1978 Alma-Ata Declaration that basically ensconced universal primary care as a goal of all health systems around the world. And I think an important sort of supporting document from the early 90s was a World Bank report that turned the traditional thinking about health perhaps on its head, where the idea was like, if you get more wealthy as a society, the population becomes healthier. But instead, this report made the argument that health begets wealth. So governments that invest in health actually create prosperity, and therefore sort of spurred additional investments in interest in primary health and healthcare around the world. It's undoubtedly the case that over the last 30 years, incomes around the world have been rising, although this is very unevenly distributed within country. But in 1990, there were 51 countries classified as low income countries, and that number by 2020 was 27. There were 39 countries classified as high income, and by 2020, that's become 80. So this is a alluvial plot that shows how countries have moved across these categories over time. This is a bit dense here, but it's just to show that investments in health have outpaced growth in societal income. So even though governments are spending more in general, they're also prioritizing health more in general over the last 30 years, reflecting this sort of idea that health begets wealth, as well as sort of this intrinsic value of health in and of itself. That said, I think there remain many challenges to the building of health systems. And I'm going to say just a word about this because I think this is the proximal context in the global context for implementation science or implementation research. And this is the WHO Health Systems building blocks. And this sort of framework articulates sort of 6 domains of sort of macroscopic pieces of the health systems puzzle. And these things are things like your workforce, the human resources of health, the infrastructure, information systems, commodities, financing, leadership and governance. And these are the things that are the pillars of public health and healthcare delivery. If we look around the world, even though much investment has gone into health, many of these pillars remain areas where there are gaps and needs. The one that is sort of very obvious, and one that you, I'm sure, have all discussed and heard about or worked on, is the issue of healthcare workers and the shortages in the healthcare workforce, doctors, nurses, and others. And you can see here that that the number of healthcare workers per population varies vastly between some of the across different regions of the world, and creates both defines the need and the kind of need for different implementation approaches and strategies to succeed. I want to just say, let me see here before I pivot to something about HIV, that even though there are these challenges, this is the overall trajectory in the last sort of 30 years has been an upward one, and I think we often focus on the gaps, and there are for sure gaps, but overall life expectancies around the world have been increasing. So if we think of implementation science as understanding sort of planned behavior change to use evidence-based interventions under constraints in global settings and in all settings really, but the operative word here is constraints. I think that in the absence of health systems, in the absence of those pillars, those World Health Organization building blocks, it's sort of almost in some ways inconceivable to think about implementation strategies. But over the last 30 years, these systems have grown quickly, and that has made a conversation about implementation strategies at this moment one of particular relevance and importance. Now, the configuration of these sort of health systems building blocks is going to differ from place to place, but I think we need to be sort of clear about how those things influence our implementation strategies. So I think I'm going to talk a little bit about some strategies, but I want to frame strategies or implementation activities in the sort of framework of these health systems building blocks by using this sort of diagram, which I am informally calling kind of an atomic diagram. Sort of the things, the valences around people. It starts with people and communities, because this is all about the health of people and communities. And I think around those things, there are health systems sort of building blocks, and implementation strategies are sort of the things, the activities, and the sort of organizational systems, healthcare worker, as well as community-based sort of activities that bring those, that make those, that bend those pillars and systems in a way to make them create value and services for people. There's a wider economic and societal context, but I think thinking about implementation strategies within these bins of infrastructure, governance, essential medications helps us understand both what we need to do as well as how to study them. I think in the global health setting, there have traditionally been research about health systems, research about interventions that are needed in many settings like bed nets. There's also been operational research, and I think the focus on context and the links between meso, macro, and micro on the other on the two sides here at implementation science helps sort of fill in those additional sort of scientific lenses that we need. So I'm gonna skip over this slide. It's a little bit probably esoteric, but I'm gonna talk a little bit about some of these strategies just to make this, I think, tangible. I'm gonna draw a little bit from infectious diseases and HIV in particular, but I think these will have obvious potential resonance and linkages to many of the things that you all are thinking about. So community adherence groups. This is a sort of an infographic, but I don't know if it necessarily describes this sort of approach very well. I'll just walk us through it. So in the HIV treatment world, over the last 10 or 15 years, millions of people have been started on treatment in many high prevalence areas, such as sort of Southern and Eastern Africa. There has been a tremendous new burden on health systems. So imagine sort of millions of people accessing chronic healthcare on a regular basis and on a lifelong basis. Many facilities became sort of very, very it became very crowded, and people had to wait a long time. Healthcare workers were getting burnt out. And in Mozambique, about 10 years ago, people reported what was called these self-forming patient groups. And so the protocol was that, patients would come to clinic every month, they'd get a quick review, they would pick up 30 days of medications, and then they would go home. That means that patients had to come to clinic 12 times a year, once a month, which there were tremendous opportunity costs associated with. So what happened was that in organizations such as sort of the government in Mozambique and MSF helped facilitate this. So patients started forming groups of 6. So in each who came from the same sort of village, in each month, one person would go to the facility, pick up drugs for the other 6 people, and distribute them when they got home. This allowed people, each person, to go to the facility twice a year, which is how often you need to go for monitoring, but also create efficiencies for other members of your community. So this is sort of community adherence group was one thing that became lumped with a number of other strategies called differentiated service delivery, in which sort of efficiencies were gained, sometimes through leveraging patients themselves as into the delivery system. So in this case, qualitative and quantitative work showed that these groups were increased retention, increased viral suppression, but also created a sense of patient activation, ownership, community relations, and social capital among groups that formed. So one set of strategies sort of emerged from a combination of sort of, I think, workforce gaps, meaning that there were not enough healthcare workers to meet the needs of all the patients in an efficient and timely way, but also infrastructural gaps. There were probably not enough clinics located in every location to make travel easy, which then incurred sort of these opportunity costs from people going to clinic. In a strategy like a community adherence group or a patient drug distribution group is the kind of thing that in that context can create sort of efficiencies and value for patients. So this has been sort of widely studied, but I imagine might have implications for, say, hypertension care as that gets scaled up, or diabetes care, or other chronic diseases, because there's nothing HIV specific about that in particular. I think we have a chapter where we sort of more systematically capture some of these strategies, but I'm just going to highlight a few others that could be of interest. And this one addresses sort of the finances and financial protections barrier that many people face. So it's not a surprise that I think healthcare costs are a large burden for a substantial proportion of people living in sort of lower and middle income countries. There are often catastrophic healthcare costs sort of associated with serious illness, but there are also sort of costs of preventative healthcare that people oftentimes may want to delay, in part because you pay for something now that you get the benefits of perhaps far in the future, which makes it seem less tangible. So there's a strategy that's been used here for, in this case, gonorrhea and chlamydia testing, but also has been used for vaccination, influenza vaccination, and HPV vaccination in middle income countries or other settings where people have access to preventative healthcare. Maybe this is testing, asymptomatic testing, or a vaccine, but there's an out-of-pocket cost, and so people delay or wait or never come around to getting it. An HPV vaccine in China, for example, is $37, which is not totally unaffordable, but it's something that people might be reluctant to pay for. And so there's been a series of randomized trials testing this idea of pay it forward. So sort of leveraging this sort of psychological observations that humans have a natural tendency to reciprocate to advance the use of preventative health. So the way this works is that you tell somebody that an NGO or another group or a patient group or a community group has paid for you to get a preventative health service, whether that's testing in this case of this paper or a vaccination, and therefore it's free to you. So when people get the service, they then are asked if they would donate for somebody else to get that service. And as in most cases, when this has been studied, both quantitatively and qualitative and in randomized trials, people generally pay. They'd be willing to pay for somebody else to get a service when they feel like they've received one for free, even though they aren't willing to pay for themselves to get that service. So it's a way of leveraging social relationships to create demand for preventative healthcare. Generally, people don't pay 100%, but they pay 30, 40, 50, or 60% of the cost for the next person. And it's a way of creating sort of a financing roadmap for some of these preventative health services that have low demand otherwise. And this is, I think something that is currently being further worked on, but is a very innovative strategy that has a place in a environment where people have sort of limited coverage for health services, limited insurance for preventative health services. A very similar one here, the revolving pharmacy model. This has been done in Kenya and other places, where if you go to this, again, this has to do with sort of supply chains and infrastructure. If you go to sort of the most rural sort of locations in many countries, there will be actually pharmacies there, but the pharmacies won't have common medications stocked because the demand, the pharmacies don't have the capital to sort of buy a bunch of medicines and then wait for them to be sold. And so the revolving pharmacy fund model is that somebody pays for that pharmacy to get a stock. So you buy a stock of antihypertensives, but because there's a demand for that in the community, people will buy it, and the pharmacist will make a profit and continue to procure the medication. So this has been called the last mile sort of investment to ensure that medications are distributed as widely as possible, given the structures that exist. Again, a strategy that I would categorize as sort of having particular relevance in a place where sort of demand and supply at the rural levels are not fully met. There is a section, one of the health systems building blocks is about sort of government and engagement. And one of the areas in which there's been a tremendous amount of innovation, I feel, from in lower and middle income countries has to do with involvement of other institutions in society to create systems for health outside of the traditional health systems. So in many places, religious leaders play an important role in how people think about their health. And as you may or may not know, there's been a number of randomized trials that demonstrate efficacy when it comes to voluntary adult male circumcision for HIV prevention. And this is a study from Tanzania that looked at the uptake of circumcision across a number of communities during a VMMC, a circumcision sort of campaign by the Tanzanian government, with and without involvement of religious leaders. So the blue is intervention. That means that they worked with pastors and religious leaders to get the message out. And in short, overall, they were able to demonstrate that engagement of religious leaders helped to advance sort of a public health campaign. And this is an example where a lot of times the ministry and may not have the resources to do comprehensive engagement and marketing, but were able to leverage existing institutions to create momentum for social change. And so something that would be a strategy that has generalizable implications for these kinds of settings. I'm just going to throw one more out at you. Let's see, crowdsourcing. Yeah. There are a number of strategies that also seek to bring the public, and which I I think of as sort of slightly different than the community adherence group example, but bring the public into creation of health service, creation and design of health services. I think for two reasons. One is that there's sort of a lot of capacity and wisdom in crowds, but also because a lot of times the public, which is the ultimate end user of the interventions that you want to promote, is going to be well positioned to think about how those things are going to be used and positioned to be kind of the most desirable. So the crowdsourcing idea comes from this notion that generally, if you ask a bunch of people about something, that there will be a large range of answers, but the median answer is often correct. This is a graph from I think one of the original papers that demonstrated this effect, where this is in the early 20th century, where people were asked about the weight of a 50 kilogram, I believe, animal at a fair, and people obviously their guesses were all over the place, but in general, the median guess was just about right, and that is consistently the case. So a number of different groups have tried to use this mechanism to, this is also from China, but has been done in other places, to create, the design of marketing strategies for HIV testing, as well as for other interventions in health. So let me stop there for a second. I'm going to turn. I think I have until I think 8:30 or 40, and I'm going to turn the second half of this talk towards sort of insights for implementation research from the intersection of from the HIV response in global settings. But I wanted to take a quick look at the questions, if there were any, but it looks like they have been answered.
Yeah, I think we have Dr. Fernandez typing away answers as they were coming in. So
okay, great. All right, so I'll go ahead and keep going here. Oops, this is okay. So my own work has been largely in the HIV response, and I just wanted to revisit this life expectancy graph that I showed earlier. This is with some of the countries in Eastern and Southern Africa, among other places, kind of in more direct view here, sort of late 90s, early 2000s. I think many settings where, for example, comparing Peru and Kenya and other places had a very similar trajectory in life expectancy that took quite a big hit during the 2000s as a result, mostly of the HIV epidemic. And I got very interested in working on the HIV epidemic, in part because even though I didn't know the term implementation science at the time, when I was training as a physician, it was obvious to me that there were many evidence-based interventions that worked. And as obvious to everybody, there were, there's testing for it, there's medications that can restore normal lifespan, there are medications and other interventions that can prevent HIV acquisition. There's lots of different tools that can be used and have been demonstrated to be efficacious in randomized trials. Yet we have, this very devastating worldwide pandemic. And it seemed to me that working on this, sort of addressing that, would be potentially an opportunity to sort of make an impact. In the early 2000s, there was also a very big drive from the global community, the donor community, to finance HIV treatment programs around the world. PEPFAR and the Global Fund are, I'm sure you're very familiar with, but did create quite a bit of financing for it. And this is a graph from a Lancet paper that that shows that in many of these countries, the percentage of financing here in blue and red, that's development assistance for health versus domestic spending on HIV. And as you can see in many places, it does play a large role, making the kind of global HIV treatment response in some ways kind of a clearly kind of global enterprise and response. So this response has definitely yielded fruit. This is a UNAIDS figure. The orange shows the number of people on treatment globally, rapidly rising since sort of the mid 2000s, and the number of AIDS-related deaths falling dramatically from 2 million, an estimate of sort of as high as 2.5 million in 2004-5, now to less than 1 million a year. So I will be, I think, quick about this, but I do think that in taking a view of the HIV response, particularly globally, there's an opportunity here to think a little bit about what lessons learned we might have for implementation science in general. And I'm just going to put out a few sort of thoughts here, maybe for further contemplation. In implementation science, we talk a lot about feasibility, and feasibility is a highly sought kind of implementation outcome. And I think that feasibility is important, but I think we also want to avoid what I call the feasibility trap, which is that what's feasible at one level of the health system may seem not feasible at another level of the health system, but also that feasibility is something that can change rapidly and can shift depending on who you are and where you are. I think at the beginning of the HIV response, there was a lot of concern that a globally funded sort of international effort to help finance HIV treatment around the world, and particularly in Africa and some places in Asia, would not be quote unquote feasible. So this is this is at the time that this was being discussed. This is John Natsios, who ended up as the head of USAID under the Bush administration, who in retrospect, what he's saying here looks silly and racist. But this was an argument that at the time many people held. It wouldn't be feasible. You need like doctors, you need infrastructure, you need equipment, but yet once having the commitment to do so, the world was able to create infrastructure and healthcare workers for this need. Paul Farmer is the counterpoint to the feasibility argument, who sort of a giant in health that we lost recently, but I don't, not taking sort of feasibility as a hard no. I think in HIV there are actually many examples of this, and I want to just highlight one other quick one, which is that in Thailand recently, the sort of Thai Red Cross, which is now called the International HIV Research Institute, I believe, landed on the idea that HIV preventative services for the transgender community would be best delivered by transgender persons themselves, because of the pervasive stigma that they felt going to sort of normal government-run clinics. They had to get special permission for because laypersons could not dispense medications. The group had to do two things. One is to do the research to demonstrate that this could be done, and number two was to pursue sort of advocacy at the ministry level to make those changes. And in this particular case, they succeeded in both. They had research showing effectiveness, but also succeeded in getting clearance from the ministry to do what at some point was perhaps thought to be not possible. The second sort of thing I wanted to put out here for us to think a little bit about was the use of appreciative inquiry. So a lot of times when we think about implementation research and we think about implementation, we start with what doesn't work. There's a strain of thought around sort of beginning to ask questions around sort of appreciating the things that do work. And I think there are some examples of this in the HIV research space. And one that I wanted to point out in particular, and Maria made reference to this, but we shouldn't take for granted the assumption that things spread more slowly, or evidence-based interventions spread more slowly in resource lower and middle income countries. And in fact, I don't know if anybody's looked at this comprehensively, but there's an argument to be made that things spread more quickly. And I want to use an example from HIV to illustrate this. As the HIV treatment enterprise really got started, sort of there became an observation at some point that a lot of patients who presented to clinic never started therapy, in part because of requirements for sort of readiness, patient readiness, and preparation. And I think the world became concerned that this was a public health issue somewhere between 2013 and 2015. And during the WHO guideline meeting in 2015, this issue came up, and the guideline committee sort of made a good practice statement that said, it's important to try and start antiretrovirals as soon as you can in people presenting with indications for HIV treatment. In fact, on the same day or very near when they were diagnosed. But at the time, there was no quote unquote evidence, so the WHO could not make a recommendation about it. But between September of 2015 and May of 2016, three randomized trials, which were already underway, were conducted and published and showed superiority or non-inferiority of same-day ART initiation for patients presenting to care. And by the following year, those studies were ensconced in a recommendation at the global policy level. Now, I can tell you that even though I can't point to a publication that shows this, around the world, same-day or rapid initiation of ART has become essentially the norm. Whereas 5 years ago, 6 years ago, people often waited 1, 2, 3 months to start after presenting. And this is a massive change in practice, and something that happened in a very short period of time. And that involved the research community, the policymaking community, and sort of patient groups to create change. And I think implementation science, taking an appreciative inquiry sort of type of view, might ask, what are the things here that allowed this kind of evidence to policy and policy to practice translation to happen so quickly? What are the conditions for it, and what can we learn from it? Oops. I have some, and I would say that in lower and middle income countries, this is not this is something that has been seen for a lot of other disease conditions before, and other areas, including, for example, the use of helmets in Vietnam, which occurred very quickly and has been the source of some interest in public health. Let me just make a couple more comments about methods for appreciative inquiry. I think that there are lots of different ways to do this. Positive deviance, I don't know if folks are familiar with that term, but is a structured methodology in which a range of service delivery organizations are examined, and the ones that are succeeding in a particular domain or practice are sort of tapped to help understand what is the sort of secret sauce at that location, and engaged in spreading their practices to others in the network. The third thing I will mention is the notion of wicked problems, and I'll be quick about this. Sidra, if you would remind me, I have until 8:30 or 8:40. 8:40. Okay.
Yeah.
about 20 years ago, maybe longer, social policy experts at a university in the United States came up with this idea of wicked problems. And they said that wicked problems are things that are refractory to scientific solutions, in part because, and there's many criteria for a wicked problem, but one of the criteria is that understanding the problem is part of the problem itself. That is to say that when you have these complex issues, it is difficult for a community to settle, a community of stakeholders to settle on one formulation of the problem, which then makes collective and unified response to it very difficult. And in many ways, I think the HIV response illustrates globally sort of a wicked problem. If you go back to 2004 and 2005, some people said the problem was that people around the world don't have access to HIV treatment because of inequities in the distribution of the drugs. Other people said that the real problem is not the HIV drugs, it's all of healthcare and health systems, and the global economic order that concentrates wealth in certain places and not in other places. Other people said it's really mostly about childhood diarrhea. That's where the DALYs are lost. So one of the big challenges here, and some people said it's about prevention, right? Like, we can't treat our way out of this, so let's focus on prevention. And I think that one of the challenges to big public health problems is sort of settling on the formulation of the problem itself. I would say that implementation science is all about wicked problems. Implementation is complicated. It's a part of a bigger process. It's often made up of microsystems and microprocesses. And so when you have a group of stakeholders working on one problem, is responding to NCDs the problem, or are health systems the problem? Is hypertension the problem, or is adult primary care the problem? I think merits some thought. But I will say that I don't know exactly how this came about, but one of the ways that the HIV community overcame the sort of wicked problem of understanding how to tackle this was indeed to come up with and disseminate sort of shared mental models of progress. And I don't know if you don't work in HIV, the numbers here are not important, but this illustration illustrates this sort of 90-90-90 idea. So UNAIDS promoted this messaging that 90% of people should have, of people living with HIV should be diagnosed, 90% should be treated, and 90% of those people should be virally suppressed. And that has become a completely and totally ubiquitous mental model for the HIV response. Everybody in the world working on HIV knows 90-90-90. And you're supposed to know your local 90-90-90, and academics know it, and public health people know it, people in community-based organizations know it. Everybody has the same mental model for success, mental model of a metric for success in their head. And I think that is sort of one general strategic approach to creating a unified response and treatment success. I think I'm going to just touch on the last two really quickly because I'm running a little low on time. In implementation science, you'll hear a lot about acceptability, acceptability of interventions, acceptability of strategies. I would say that one of the things that the global experience with HIV has taught us about implementation is that acceptability is not enough. That we need to move beyond acceptability to understand what it is that people want, and therefore what it is that people will use. And I think that the HIV field is replete with interventions from injectable PrEP to vaginal gel to VMMC that were considered acceptable. Like, if you go and get a group of people and you ask them if it's acceptable using some scale, people will generally say that it is. But in reality, that doesn't mean that they want to use it. There are different methods for understanding preferences, for deepening our understanding of what people want beyond sort of the notion of acceptability, and random utility theory, which is used in economics and marketing, is one of these methods that we in implementation should be thinking about. This is an example of a question that you would get in a what's called a discrete choice experiment, which is a method that is built on utility theory. And the theory basically says that people want to be happy. Getting stuff that you want makes you happy. You can't have everything that you want, so you have to choose between things that you want. And choice experiments try to uncover the features or the attributes of different goods and services that people actually want, and therefore can help you design things that people want and will use. A choice experiment asks people to choose between two hypothetical goods and services, in this case, a clinic. You might take a moment and look at this and say, which clinic would you rather go to? And then you're presented with this choice again and again and again, each time with the attribute levels scrambled. And based on your choices, we can learn what it is that people want. We did this experiment in Zambia, and it turns out that people really want nice healthcare workers. But that's not the interesting thing about the choice experiment. What was interesting was that we learned that it was worth 40 kilometers of travel distance. So people would be willing to trade. They would be willing to go to a clinic that was 40 kilometers farther than in order to get a nice healthcare worker. They were also willing to wait 15 hours or longer to get a nice healthcare worker, but it helps bring into focus what it is that people want, and therefore what is the sort of design of implementation strategies. My last sort of thing here is just about failures of design as well as failures of implementation. But let me just skip this one and end with a couple of conclusions. I think implementation science is an area of rapid and robust growth. I think we can take lessons from implementation science and apply them to many global problems on a global scale. We can also continue to learn from those problems about implementation science. And I think that it's important for us to, as the science sort of globalifies or expands globally, that we think about not only the content, but how it's produced. And a topic I didn't get much into today around sort of a balanced view globally of these methods is also important to keep front and center in that conversation. So let me stop there. If I have, I've gone a little bit over time, but hopefully leaving plenty of room for discussion.
Thank you so much for that, Dr. Geng. We do have a question here, but just before we get to that, I'm going to launch the poll and give everybody a couple of minutes to answer that, and then we can get on to the Q&A. Just as a reminder for everybody that, the resources will be sent out to you once they're uploaded. I am not going to be sending out a link right now, but I am getting everybody's emails. So thank you for that. I'm going to take note and give you access, and then you can access the recordings once they're uploaded and the presentations. And also thank you again for using the Q&A box. I won't be noticing any questions in the chat if they come up there, but just in the Q&A box is where they go. And I haven't seen any in the chat so far, so that's great. We'll just give you a minute more here for this poll, and then we'll hand it over to Dr. Fernandez and Dr. Geng for any remaining questions and discussion on the previous presentations. Okay, so I have ended the poll here, and we have one question in the Q&A box, which is, what are the most common challenges when implementing in LMICs? And are there any particular strategies that work better than others? Are there particular IS frameworks that situate themselves well in LMIC contexts?
Thank you, Sidra, for reading that. Maybe you can take it off of the screen share for a moment here and just keep track of our time. And then I'm going to punt that to you, Elvin.
Yeah. So, I think maybe two parts to that question. I think number one, consulting the frameworks and theories that are being used and discussed in implementation science, I think are helpful. So, CIFR is a very broad and flexible sort of set of constructs that bring our attention to sort of a universe of things that could be affecting implementation. There is a modification of CIFR published by Means et al. And a group from the University of Washington that tries to add some more domains that are more relevant for LMICs. The behavior change wheel, for example, from Susan Mishi is also very useful. I personally like normalization process theory, even though that's very a bit sort of academic in a way. But I would also say, though, that that we can and should be the final judges of their utility. And in many cases, people who are working in LMIC contexts will look at these and say, you know what, this isn't that useful for me. And if it's not that useful for you, I would say there's no reason why we need to sort of either stick with them or use them or sort of make apologies for them. They emerged out of people working mostly in high income health systems. And so high income country health systems. And so by nature, they're not going to be a perfect fit. So I guess I would say maybe use them because they might get you some ways down the road, but they might not get you all the way down the road. And when they stop being useful, we will look for other things. I would say that there are other sort of ideas that are very helpful for implementation that are not necessarily branded as implementation sort of research. And there's ideas from economics, from development economics. There are sort of notions around sort of based very much in sort of people's contextual knowledge about their regional health systems that I think definitely need to be brought into the mix when understanding these situations and implementation problems. So I guess that's might be where I would start. Yeah, and I do think in implementation science there might be a tendency to like overly elevate some of these frameworks, where people are like, okay, so this is the framework, and yeah, I'm reminded of that Buddhist story where Buddha says that if you have a raft and you cross the river with the raft, when you get to the other side, you don't take the raft with you because you used it to get across the river and you don't need it when you're going down the road. So yeah, not sure that's helpful, but.
No, thank you. Thank you for that, Dr. Geng. I think Dr. Ramaswamy had his hand raised.
Yeah, thank you. Can people hear me?
Yep.
Yeah, I just wanted to jump in on that question as well. You'll be hearing from me in a few minutes, but in any case, I think that's a really important question. And as Dr. Geng said, one of the things that we have been discovering, a lot of the global health work we've been doing, is that that there is a lot of pressure to use these more common frameworks, such as CIFR and the behavioral change wheel, because there is a perception that both if you're writing a grant that is being reviewed by a study group that is essentially Western-based, or you're publishing in a journal like Implementation Science, that the reviewers are going to come back, and if you therefore use your own framework because that the traditional frameworks don't work for you, that you're going to get rejected because you're going to get answers from why are you using some new frameworks when frameworks already exist. And a lot of the work that we've been doing has been to kind of walk that tightrope. So not to say invent your own framework, because there are already hundreds of frameworks that exist. And so there's no immediate case for saying you need to start with something new. But what we've been telling the researchers and practitioners that we work with is be critical about these frameworks. This is what Dr. Geng said as well. It's not just because these exist and these have been widely used and they are part of the published literature, doesn't mean that they always fit for you. And this question of, is it the right fit for living low and middle income country settings, is a important research question that we need to continue to think about a little bit more. But what we have been advising those who are using these frameworks is think critically about why you're using them, document where they work and where they do not work. Make sure that you're publishing where your experience of these frameworks and places where they need to be adapted or changed so that they can work better in your context. And so being able to work, and I think at this point, a few years ago, it was more difficult for researchers from these kinds of settings to get the attention of the so-called experts in the West. I think that is beginning to change. I think there is a recognition in that, as Dr. Geng mentioned, that the field of implementation science has been overwhelmingly dominated by researchers from the West, and there is a need to change that. There's a need to kind of democratize the process of how implementation research gets initiated. And so being able to I think there's a lot more opportunity now to be thoughtful and critical of these frameworks. So my kind of general advice is use the ones that are most common, because as Dr. Geng said, CIFAR is so broad that it has a lot of applicability and utility. But but make sure that you're thinking about adapting those in a way that fits with your particular context.
Thank you both. I'll just add just a couple comments. I think that there was actually a question that someone asked about, is it possible to do implementation research to understand the mechanisms that make or break implementation, and that based on that learning, come up with an altogether new theory or modification of an existing theory? And I basically said, absolutely. And I think that that's what part of what Dr. Ramaswamy is talking about, that we have to question our assumptions and recognize that these theories and frameworks, the majority are just guides. And even particularly the developers of the frameworks are saying, please, give us information, help us understand these better, help move the field forward. I will say that, though, that they can be useful. Many times when we do trainings on implementation science, people ask the question, how do I know what theory or framework to use? There's so many. And the answer, or part of the answer to that question, is it depends what you need it for. Do you need it to help you understand what are the possible factors that could be influencing implementation? Are you using it to help you determine the outcomes of a particular study? And the article that I referenced can help you sort of find what types of frameworks might be most helpful. But again, I think that we haven't really talked too much about this, and looking forward to Dr. Bro's presentation, engagement of communities and interested parties is an essential piece of everything we do when we're planning implementation strategies, when we're planning implementation research. And a critical look, an engaged, participatory, critical look at these frameworks and which ones apply for us and what pieces of them apply in this context, I think that has to be a very essential part of this process. Do we have time for another question, Sidra?
We have about a minute left. There was a question about resources. Implementation research is interesting, but involves money and materials for interventions to implement. So isn't it difficult to conduct? I don't know if anybody wants to share a word on that, and then we can move on to the next presentation.
I mean, one thing that I'll say, and then see if anyone else has a comment, is that much of the work that we do and is in implementation research is things that are already happening, right? They're already being used or they're already being introduced. And implementation science and implementation research is sort of, can be overlaying questions about what you're already doing. So a new innovation comes, a new guideline comes, a new program that is being implemented in a setting. And so implementation research could be just asking the right questions about what's already happening. And these types of observational implementation, natural experiments, so to speak, of implementation strategies and processes, this is a very, very important in advancing the field of implementation science. So I think that yes, prospective, huge studies can be very expensive, but it doesn't have to be. And see if anyone else has another comment on that.
Yeah, actually, this is what my presentation is going to be about, is how do you integrate implementation science into ongoing quality improvement efforts within organizations. So it doesn't necessarily need to be something that is an implementation study that needs to be launched and resourced. But part of this is being able to think about how do you apply the concepts or the kinds of things that Dr. Fernandez talked about in kind of your everyday improvement work that you do, so that you're implementing and sustaining some of the change solutions that you come up with. And that is the focus of my talk that you will hear very soon.
Thank you so much, Dr. Ramaswamy. If Dr. Zhu would like to make her comment, and then we'll get to Dr. Geng.
Yeah, thank you, Cedra. I'm audible?
Yes,
yeah, just quickly actually reflect what Dr. Geng and Rahid that you mentioned in terms of the implementation strategy. When we're working at the WHO for the NCD service integration guidance, in a way, we are looking sort of an implementation strategy to implement multiple NCD interventions. And then if we use the Maya language, basically multiple things to lower middle income country in which have low resources, there is constraint, the capacity have a constraint. But one thing we actually do try to find, we got a lot of evidence actually from the research, from the implementation research in a lower middle income country. One of the example actually mentioned by Dr. Geng is on the experience from the HIV/AIDS many years of practice in African countries when they have a higher HIV/AIDS prevalence, but some of the countries also have coming higher diabetes or hypertension prevalence, and those experience is used by HIV/AIDS, but now borrowing to the NCD's service, the guideline workers, the policy makers, and also the frontline workers in the country to see how we actually can use their strategy just to leverage to help the people access to NCD care and to get better care to be sustainable for the whole health system, but deliver the outcome for the patient needs. I think there is something we're all coming together to talking and to want to realize the same thing in the country. Over.
Thank you, Dr. Zhu. Dr. Geng, did you have something you wanted to add?
It's okay. If we're out of time, I think it's fine. Yeah, I was going to make a comment about the pragmatism of implementation research, but I can answer in the chat.
Okay, you're welcome to make a comment if you want. I'm sure this is very valuable for all our attendees.
Maybe I'll just be very brief. I'm sure my colleague Rohit is going to talk about this in a minute, but I think in general, when we're seeking to understand implementation, I think in some ways the overriding sort of principle here is pragmatism, right? And so if you have things that you want to understand about an implementation process, I think there are ways to do so in a way that's not resource intensive. And it starts with sort of conceiving of, in my view, conceiving of the complicated multi-level activities that implementers undertake in a slightly more sort of systematic way. And then that might open the door to making some sort of measurements and understanding how they work. But that's so I think that there's a range of possibilities here that are, some are more resource intensive than others, but oftentimes something is accessible even under constraints.